let me get into describing our practice as it was before April 2013. We have a solo family practice. When I say we, my wife is my office manager and my boss. And I just do what I'm told, and when I do that, things usually work out okay. We are in a suburban area in the Northeast. I will say Maine is not your typical New England state because we're fortunate enough to have Governor Paul LePage, who always is entertaining. He really likes to tweak the media. I think a couple days ago he put out there that he would like to bring back the guillotine for drug dealers. So he loves to stay in the headlines, which I think is good. And anyway, so Maine's a great place. Our office is attached to our home, again, reminiscent of the model my father practiced in, and as many folks here have experienced, either now or decades ago. We had lean staffing. We had 1.5 full-time equivalents, not including my wife, who is our part-time office manager. I gave up hospital patients quite some time ago just because it was an efficient way for me to practice. Did not do nursing homes, and also gave up obstetrics quite a long time ago. Our practice consisted primarily of adult medicine, particularly geriatrics. We never accepted Medicaid, and we got to the point where we could no longer accept new Medicare patients just because it was not financially viable for us. We were accepting new commercially insured patients and cash patients. The medical climate we practiced in, Portland is an area, the largest city in Maine, which isn't really saying much. It's got about 80,000 people. There's one academic hospital, I think there are about 600 beds. One community hospital of less than 200 beds that went bankrupt and was bought out by a different academic hospital from another town trying to get a foothold in the city. Hospital-owned practices and other big box practices dominate the landscape in terms of marketing and contracts with insurers. The academic hospital system, the 800-pound gorilla, has been swallowing up as many specialty practices as they can, to the point where the Federal Trade Commission actually stepped in when they bought the 2 very large cardiology practices. It was a big enough deal that that they had to go in there and broker that to be sure that there was not a monopoly. Independent PCPs have been scrambling to survive, as they have been in other parts of the country as well. Often they try to find niches. Some were doing Botox, some were limiting their practice to osteopathic manipulation, doing weight loss on the side, Suboxone, or getting medical directorships at nursing homes or insurance companies, or just being forced out of medicine or out of the state. The problem that we were having was we really cared about our patients, and we wanted to provide as good a care as we could for them, to the point where we were essentially providing concierge care, but getting paid Medicare rates, if anything at all. And we realized that this was not really a way to sustain our practice. After being in private practice for about 12 years, we saw that every year our bank account was shrinking, not getting any bigger. And when you're losing money on every patient, you really can't make that up with volume. So, the last straw, as for many of us, Obamacare. We were told by the Physicians Health Organization that managed most of our insurance contracts that they were going to be forming an accountable care organization. And Dr. Huntoon and others have mentioned that. And we realized, again, that the hospitals would control the revenue and give the physicians crumbs if there were really any savings, which again, we didn't really think there would be anyway, looking at how they were being set up. Also, that left us in a moral dilemma because I think that accountable care organizations, the way they ration care and deny care, are not only financially not feasible, but they're also, they put you in a big moral dilemma. So we really did not want to participate with that. And also, as other people have mentioned here, they were going to require us to become a patient-centered medical home, which was kind of ironic because you can't be a more patient-centered medical home if you're a solo family practice. The communication is great. You communicate with the patients, with your staff. But I went and looked up what just the requirements of what a patient-centered medical home were, level 1. The list of requirements was 45 pages long. And talking to colleagues that had completed the process, God help them, said it took at least 200 hours of non-compensated time to get that done. So we were just not willing to do that. And the really last straw was when they told us we had no choice. Well, we felt we did have a choice. Very hastily, we resigned from the Physicians Health Organization that was not really helping us. We opted out of Medicare effective April 1st, 2013, and a lot of our patients thought it was an April Fool's joke. And we also canceled all third-party insurance contracts. What we did, we took a page out of Dr. Keith Smith's book and published our cash fee-for-service prices online in our office. Because we were no longer doing meaningful use, we very happily junked our EMR, which we hated in the first place. I went to GoDaddy, and for $100 we had a do-it-yourself website, did a little bit of advertising on talk radio, and as Dr. Huntoon had said, we got a lot of free publicity, which is the best publicity you can get. The results, our most demanding PIA patients left. You know, they say 10 or 20% of your patients are 80 to 90% of your work. Well, they left. That was wonderful. Unfortunately, many Medicare patients left because we weren't accepting their insurance. HMO patients were forced to leave because of network issues. I could not refer patients because they needed an in-network PCP. Some PPO patients remained and got reimbursed. Some did not get reimbursed but continued to stay anyway. What happened was we did get a lot of patients with high deductible plans or no insurance coming in, and we started seeing younger patients and more children, which we were happy about. I want to go over some of the pitfalls of going to a third-party free practice, especially if you do it as hastily as we did. There's a lot of confusion about it. No matter how much effort you think you've put into education, people will be confused. People will think you're a greedy doctor because you're not going to accept their insurance, you just want their money. You will find support is a mile wide and a foot deep from both patients and colleagues. Patients will say, "Doc, that's great, you're really giving to the system, I agree with you 100%, but I have really good insurance, so I'm going somewhere else." Or colleagues often will be jealous, they might speak behind your back, but then they will also say, if you're still in business in a couple of years, tell me exactly how you do it because I'll do the same thing. Who stays with you is very unpredictable. I've had millionaires leave and people that have no money stay. You'll get unwanted attention from drug seekers, crackpots, and solicitors because, again, if you're a cash doctor, you get people's attention that you don't necessarily want to have. You're just firm with them, and actually I found some of the drug seekers, if I had a lot of spare time, I just let them go on for a while because it was actually really entertaining. Before I tell them they weren't going to get what they wanted and they stormed out. And patients will be evasive, if not manipulative, in that they'll say, "Doc, I'm going to stay with you, but could you please refill all my medications for a year and I'll come in, I'll promise I'll make an appointment at some point. So you do have to set limits. Specifically the pitfalls of cash fee-for-service. People started thinking that we were an acute care clinic, which we were not. Many patients who stay will attempt not to come in at necessary intervals for appropriate medical care. I had people with diabetes and uncontrolled hypertension that were trying to come in once a year when they really should have been coming in every month or two. There are a few good benchmarks for cash prices for fee-for-service primary care. At least there were at the time. Maybe they're being developed now, but it was a challenge. Income becomes very unpredictable because you think all your patients will stay and you're amazed at how many don't, and you're sitting there not getting paid. Patients focus too much on reimbursement from insurers and not on the quality of care they get. And we found that it was not a sustainable model for us. A lot of people just saw us as the doctor you went to until you got insurance, then you went somewhere else. So we did not find that personally very satisfying. But as Winston Churchill once said, if you're going through hell, keep going. We had broken free from third-party payments, and we were not going to go back to it. We just had to find another way to do it. And through AAPS, we met a couple crazy young guys by the name of Doug Nunemaker, Josh Umber, and they were describing a model called direct primary care. And it really sounded too good to be true. And it's not. What we did was we set up a monthly subscription for unlimited primary care visits. We charge $50 for an individual, $95 for a couple, $140 for a family. Discounts for prepaying for the year in advance. And because the VA is not taking care of our veterans, we thought we would do at least something to try and do that. So we give veterans a 10% discount on our subscriptions. We provide labs, generic medications, and vaccines at our cost, including phone calls, email access, visits of 30 to 60 minutes, and for a small extra fee, we do house calls. The payoff. When patients get it, they're thrilled. You have to convince them, yes, you can come in as often as you need to, and I'm not going to ask you for money on the way out if everything is paid up. Also, personal satisfaction. It gives us more time. Professional satisfaction as well. Our income is predictable, and now we can focus on keeping patients well. I don't like to have to wait for people to get sick in order to make a living. So direct primary care is a way that you can escape that sickness mentality. And freedom. Some of the pitfalls of transition. We didn't go, because we made the transition from insurance to cash fee-for-service, and so many patients had been faithful to us, it was hard for us to say a year later, okay, you have to make this another transition tomorrow. So we've been in a transition phase, and we're getting more aggressive at phasing out the fee-for-service. We found that we were competing with ourselves because people were saying, well, if I only have to come see you once or twice a year, I'm better off paying as I go. So we're really trying to break that. So we've been competing with ourselves, which we are getting ourselves out of that. So don't do that. Make one transition, not two. It's an unfamiliar model to the general public. Fortunately, it's getting more notice. There's a lot of confusion with concierge. We don't really have time to talk about that. But again, people think you're greedy. You're not. It can become an obsession when you're doing something like this. You can focus on it too much, take too much on yourselves, as physicians tend to do. The best advice I can give you is compartmentalize the time you take to do this. Spend time with your family, pay attention to them, and don't always talk to your wife about how you're going to change your business model. She doesn't want to hear it all the time. Considerations that you should look at as you go into direct primary care or cash fee-for-service. How do you support yourself and your family during the transition? We felt we decided to take on some debt while we did that. Certainly some people moonlight or do other things. Decide whether or not you want to use an EMR. We were very happy to get rid of ours, but if you have one you really like, that's fine. But again, you don't have to worry about meaningful use. So you're free to make the decision for yourself. Do you make an immediate transition or do you do a hybrid practice? And I think Phil addressed that. If you do a hybrid practice, you're not really reducing your overhead. So we were happy that we made a clean break in terms of getting rid of all third-party reimbursement. Do you opt out of Medicare? We did, and we were very happy to. I was going to say the only reason not to is if you're going to moonlight and you need Medicare to do your job, but I was really happy to hear that maybe you could work at an urgent care without being opted in Medicare. What is your time frame? Plan ahead. Other considerations. With your practice transition, do you do it yourself or do you talk with consultants? Maybe it's worth talking to a consultant to get some tips if you know someone that's good. Subscription management. How do you manage monthly fees? Certainly, we use Hint Health, which does it on a swipe platform. That way, we don't have to keep everyone's credit card or bank information, so it's much more secure. And Josh is somewhere in the room. I believe Atlas MD's EMR will also do that. If you use an EMR, be sure it is DPC friendly. Atlas MD, Inlight, and Elation, as far as I know, are the only ones that are. Marketing. Basically, I'll summarize. Free is better, and if cheap is right behind that. Don't spend a lot of time in marketing. The best you can get is word of mouth. Best patients for direct primary care. Any patient who wants unprecedented access to a caring personal physician, but there's a corollary, they have to be willing to pay for it. The uninsured, they really appreciate what you do. People with high deductibles, because what I tell people is, my job is to try and keep you as far away from your deductible as possible. And they appreciate that because it's their money. It's not money that the insurance company is paying out. PPO patients, if they don't need referrals, they tend to be happy with DPC. Folks that have faith-based sharing ministries, like Liberty or Samaritan, etc., they realize that you are saving them money. Also, as mentioned here before, employers, the ones that are self-funded, they see the value because it's their bottom line. Money is on their bottom line that's being saved. So I apologize, I spoke really quickly because the time frame is very limited, but I thank you, and I'll answer questions after the panel is done.